can you, Pierre, elaborate a bit? So you showed us in the previous slide how you were blocking these channels. So a line of ablation that transects the channel. Can you tell us? And you were also showing us where you would put that line along the channel on the thinnest area in order to be transmural. Can you tell us what's your local endpoints? Because I believe that these cannot be blocked.
Yes, that's very important. It would be quite tedious to demonstrate block on each of the CT channels, and definitely would require extra catheters. So this is not the approach we've been following. Rather, we look at electrograms where we transect the isthmus, and it's a good thing when we no longer see any lava abnormal potentials, but this is not always possible because it's just one line and you get far field activity even from the lava that are adjacent, because it's important to understand that this approach is quite different to the lava elimination. We leave plenty of lava. We just block what we think is going to be responsible for the VT. And so the simplest and yet quite robust endpoint we ended up with is just to pace with the ablation catheter the standard loss of capture with 10 milliamps and 2 milliseconds pacing strength. And we're happy when we lose that capture. Again, this is probably more meaningful in really thin areas where you just have 3 millimeters wall thickness as compared to what you have in healthy myocardium, I think. And, you know, it has been quite successful. And then we have a more global endpoint, which is non-inducibility, of course. This one has been there forever.
Yeah, but it's very important, this non-inducibility thing, because this is very reassuring with respect to the efficacy of the procedure, because our experience has been that, you know, by doing so, the majority of patients are non-inducible, and you are out of the lab in less than 2 hours for a VT ablation. So it's almost as fast as a PVI, very, very close to being as fast as a PVI for AFib. But if there's something that remains inducible, you convert to the pace mapping and entrainment mapping strategy, and you chase these remaining VTs that are usually super fast and maybe different. But what I'm saying is that the endpoint being the same, it's a win-win, because even if you have still inducible VTs, you will gain hours of procedures by doing so, with no risk, and the same EP endpoints. That's important for the final endpoint.
Absolutely. And in addition to that aspect, I think one of the things I have been considering very important during my entire career is that we have to make it as easy as possible for the patient. And this means that if we can work in sinus rhythm, if we can stay away from general anesthesia, from hemodynamic support, etc., we are probably doing a better job for our patients. They will recover faster, have a better experience. And this approach is really suited for that goal, where we don't even try to induce before starting the ablation. So we would straight go to the point, devote really the time in the lab to ablation, which is what cures patients or what improves patients, rather than trying to understand the substrate mechanisms, etc. All this part is taken care about by imaging and is defined before getting to the lab. So in the lab, it's really about treating the patient quickly, efficiently, and with the least amount of stress as possible. So yes, you're right. If patients are inducible at the end, we would convert to a more conventional approach if we think that what is inducible does not use the CT channels. And we have to check that. It's important, And in 20% of those cases, it's in fact improperly ablated channels or sorry, there are some interferences now. Insufficiently ablated channels or reconnected channels that we have to take care. And if it's not that mechanism, then we also learned a lot from images, because we have another type of VTs that might be inducible after we took care of the CT channels. And these are typically faster, may not be that sustained, may be polymorphic, and typically use the substrate in the periphery of the scar, where the transition from dense scar to healthy myocardium is very smooth and take 2 to 3 centimeters. This seems quite characteristics. Yeah, exactly. That's the area Hubert is pointing out at now. And when you have a very abrupt transition between the dense scar and the healthy myocardium, you don't see those arrhythmia. So that's also one of the benefits of using images.